All right. So first and foremost, I want to thank all of you for giving us this opportunity to share our research with you. This is something Andrew and I are really excited, and on behalf of all of our team members, Gregory unfortunately couldn't be here tonight. So today we're going to be discussing the role of aeromedical transport and time-sensitive trauma that occurs in rural areas. And so the way we're going to go about doing this, I'm going to have Andrew share the entire poster, and then I'll just kind of talk us through it. This way you guys have all the visual aids and everything. All right, so traumatic injuries.
Introduce yourself.
For those of you who don't know me already, my name is Tom Banzon.
And I'm Andrew Wolfram, third-year medical student. Happy to present today.
Great. Okay, so traumatic injuries are the leading cause of death for Americans aged 1 to 46, and this costs our nation over $670 billion annually. So despite accommodating only 19% of the US population, over half of fatal motor vehicle crashes occur in these rural regions. So obviously, access to immediate and life-saving care in these areas is pretty limited. So we know from past published data, increased time to transport leads to increased morbidity and mortality. So the goal of our poster is to assess the average aeromedical transport times of this company's survival flights, responses to rural traumatic injuries across 18 trauma-specific ICD codes. So just to help paint the picture of the current challenge, I want to share some important facts that we have. So approximately 4.5 million people live in what are known as ambulance deserts. These are defined as populated areas that are over 25 minutes away from an ambulance station. So we know from previous studies a 1.8-minute increase in EMS response time has been shown to significantly impact patient mortality and emergency department admissions. So compared to ground ambulances, aeromedical transport crews very obviously travel faster, can cover wider areas, and provide more advanced critical care. Even though they're not limited by ground traffic, they are more expensive. And typically, patients transported by helicopter are more severely injured. They have longer transport times and require more hospital resources than ground transport. But interestingly, studies have shown that aeromedical transport patients are more likely to survive and be discharged home compared to ground transport patients. Another important topic that we talk about quite a bit on our poster are critical access hospitals. So critical access hospitals are defined as having no more than 25 beds and are located at least 35 miles from another hospital, or they can be designated as a necessary provider by their state. So these hospitals typically can't provide the same level of care that is needed to treat, really acute traumatic injuries that are highlighted in our ICD code selection. So EMS teams typically resort to aeromedical transport for patients when there's geographical challenges such as inaccessible terrain and vast distances, and so that hinders the use of ground transportation. Helicopter emergency medical services are crewed by a flight medic, a flight paramedic, and a flight nurse. So they're equipped with all sorts of advanced medical gear such as blood products, IV pumps, mechanical ventilators, medications, cardiac monitors, defibrillators, all sorts of stuff. So in our study, again, we utilize survivor flights, electronic medical record database. We obtained 17,716 patient records that spans 11 states, and the time period is from January 1st, 2021 through December 31st, 2023. So we picked 18 of 85 ICD codes based on their traumatic acuity and the time-sensitive nature of their treatment. And beyond that, our additional criteria included having complete EMR records of validated and time-stamped data. So after all of these criteria, we ended up with 4,503 adult and pediatric trauma cases. So we did a single factor ANOVA analysis on trauma types and compared the total average transport times. Then we did a 2-sample t-test to compare the average scene response times and the interfacility transport times for each of the different trauma types. So if you look to figure 1 of our research poster, we determined the total average transport time of cases to the tertiary care facility. So the single factor ANOVA on trauma types found that burn victims actually had the longest average transport times, even though they only accounted for roughly 3% of our injuries. On figure 2, we compare the average aeromedical transport response times from the point of injury to a tertiary care facility. So this is termed scene response. And then we compared those to the response times from a critical access hospital to a tertiary care facility, and that's termed interfacility transport. So the two-sample t-test found a significant two-tailed p-value of less than 0.05, with scene response having a 31-minute and 2-second faster response time than interfacility transport. So if you take a look at figure 3 then, we show the total proportions of the different ICD codes. So traumatic injury is typically, traumatic injury is essentially multi-system trauma. So this was the largest proportion, and obviously so. And that made up 61% of the total overall. So we also provided timestamps for burns, imputable fractures, non-imputable fractures, hemorrhage, pain, traumatic injury, and brain bleeds with traumatic brain injury. The average scene response time for that was 31 minutes and 2 seconds faster than interfacility transport, and we're able to validate that with a p-score of less than 0.05. So figure 4, on the other hand, portrays the average transport timeline for critically injured patients from a point of injury to a tertiary care facility. And in analyzing that data, we found an average total transport time of 2 hours and 5 minutes. So our research examines the average response times of survival flights, aeromedical transport, and rural trauma cases using, again, 18 different trauma-specific ICD codes. So helicopters transport patients faster directly from point of injury to tertiary care facility, as opposed to transfer from critical access hospitals to tertiary care facilities. So burns took the longest total transport time, likely due to limited burn facilities in rural regions. If you can draw your attention to map 2, we have points of all of the burn facilities in the US. If I remember correctly, there are I think it was 60 that is not listed because they're not associated with the American Burn Association. But if you look at states like Oklahoma and like Arkansas and even in Georgia, there's not many burn facilities. And so it's kind of obvious like why it would take longer depending on where the accident is, despite having a helicopter transporting you to that place. So we identified 4 potential barriers that prevent patients from getting their definitive treatment. And so things like limited ALS trained paramedic staff, limited trauma and burn centers, limited hospital licensed physicians, limited medical equipment, and just overall drawn out paperwork that occurs during the transfer process. And we hope that our research will shine a giant spotlight on areas needed for potential improvement, and we can dig into that in future studies.
So then I'll kind of go through those figures a little bit more because we referenced them, but now we'll just kind of blow them up so they're easier to see. So map 1, we took from Dr. Junk. Okay.
Turn your volume.
Turn your speaker up. There you go. All right, so map 1 we took from a professor named Dr. Junk, and there were geographic disparities that exist in access to EMS service. So basically, takes a map of the U.S. There's a couple states, 1, 2, 3, 4, 5, 6, 7 that didn't participate, but the rest of them you can kind of see. It's a little blurry, but the lighter typically have less EMS access. So if you look in Georgia, there's not a ton of EMS access here, whereas oh wait, sorry, just kidding. This is the burn center stuff. This is the rural counties. So rural counties are darker, urban counties are darker blue here. So darker green would be the rural. So obviously in the far west, you see South Dakota, Montana, Utah, Nevada, New Mexico, there's a lot, and then West Texas, there's a lot of rural stuff. So these areas obviously have less access to emergency medical services, and you can see that kind of mirrored on the burn maps. Like there's almost none in this northwest area, none in New Mexico, 1 in Nevada, but most of the state not really. So you just see like the geographic disparities there, whereas in the northeast there's a ton of burn centers. It doesn't report it here, but there's a lot of urban areas with a lot of access to EMS places. So that's why we put that there. The methods, here were the 18 ICD codes. You probably didn't have time to read it while we were doing it, but we basically looked at, so we just organized them by alphabetical order here. Pain, trauma related. So they pull up to the scene, they see the patient's in pain. They list it as their primary intention pain. Then hemorrhage bleeding, they're bleeding out. They need to stop the bleeding first. They label that as hemorrhage. Fractured skull, facial burns. Obviously, they have a fractured skull or somewhere on their face is fractured. Traumatic brain injury. You know what that is? Subdural hemorrhage, or where what that is? Epidural hemorrhage. Subarachnoid hemorrhage, fractured cervical vertebrae, the neck, fractured ribs, sternum, thoracic spine, fractured lumbar spine or pelvis, fractured shoulder or upper arm, fractured forearm, fractured wrist or hand, fractured femur, fractured lower leg, fractured foot and toe, traumatic injury, and burn. So as you can see, there's a lot of fractures. We'll group those into, so here you see the fractures amputable. We grouped all of those. When they're extremity injuries like wrist and hand, it'll have an A next to it if it's the amputable one. And then if it's non-amputable, it has a B next to it. So those are just fractures that are on the axial skeleton, so like lumbar spine or cervical vertebra. Is that it? And facial. And then burns were burns, hemorrhage, bleeding, pain. And then we combined all the brain bleeds together. So we did TBI, epidural, subdural, subarachnoid together. And then we compared the transport times and we found that burns was the only one that was significantly different. All these other error bars match with each other or intertwine. So then this is the only one that's significantly different. There was a p-value of like 10 to the negative 23 or something, but we just put, you know, less than 0.05. The reason for that was the limited access to the burn centers. You have to travel a lot farther to get to the center on time. So that's kind of why that's the case. This one, like Tom said before, a scene response, the helicopter responds to the scene. So they pick up this, let's say, the person in a rural area driving weirdly, pull up in the ditch, they're in a car crash. So the helicopter meets them at the ditch at the point of injury. That's where they were injured. And then they get the call from dispatch. Someone sees it. They're like, okay, this person needs help. So then it takes up the crew on average about 8 minutes to get ready, and then about 23 minutes to fly to the scene, and then landing to the patient. So like they need to stabilize the patient and basically leave with the patient. So that takes another 10-ish minutes. And then they get the aircraft ready to fly. And then they fly to wherever they need to go. So that's the transit with patient. And then they hand the patient off at the tertiary care facility where they can take care of all of those traumatic injuries definitively. So then the interfacility transport is where an EMS team, let's say some sort of ambulance, has picked them up at the point of injury already, brought them to the nearest hospital that probably can't handle all the injuries that the patient sustained. So then the helicopter picks them up there and then brings them to the tertiary care facility to where they can actually do all of the definitive care and definitive treatment. So as you can see, there's like a 30-minute difference here, which means that it takes a lot longer for an injury to be stabilized because this isn't even factoring in the other time that the emergency medical services like the ambulance did when they were with the patient. So they could have been injured way over here and then plus the extra 30 minutes. So in general, this basically shows that it's better for the helicopter to pick them up at the scene than for an ambulance. And then there's a significant difference there. This one was just the distribution of ICD codes. So as you see, multi-system trauma, that means over half the time, the person has a lot of issues going on at once. It means they need a lot of specialized care because they have broken this, they're in pain, they're bleeding, they're this, they're that. They have a bunch of different things going on. Bleeding was the second one, pain, the third one. Fourth was other, which is all of these fractures kind of and epidural kind of grouped into one. This because it made up less than 100 cases, as you see here. 6% was traumatic brain injuries, 5% subdural hemorrhage, 3% subarachnoid, 2% burns. So that's kind of the data. And then this was taking the average transport time of all of the scene response and the interfacility transports took about 2 hours and 5 minutes on average. That's pretty much it. You guys got any questions for us? There's a lot of information at once, so I totally understand.
Hey, yeah. First of all, excellent presentation. That was really good detail. Uh, yeah, and I appreciate you guys going through it, especially with the close up, because on a poster I'd be able to read it much better than on this screen. So that's good. Um, let's see. You answered some of my questions as you were going, so I'll have to fix this. Um, The first one was on that one graph that compares that the tertiary